You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently had the opportunity to sit down with two pediatricians from Cincinnati Children's Hospital, Dr. Kevin Dufendach, neonatologist and biomedical informaticist, and Dr. Andy Spooner, the health system's Chief Medical Information Officer. Our conversation centered around the evolving world of clinical informatics, the emerging role of artificial intelligence, and why more and more pediatricians are starting to think like informaticians. Let's plug in. Gentlemen, welcome to the pod. Very excited to have you here. Andy, let's get started by you telling us how you got to be in this position of power, this unholy position where you are seemingly in charge of healthcare informatics for all of pediatrics in the United States.
Mm-hmm. Yeah, right. That's right. Well, my journey started where it starts for almost all of us, which is the NICU.
Amen.
Amen. Everybody's got a story of some task they tried to automate when they were a resident. And for me, it was calculating nutritional loads for neonates, and got a lot of positive feedback. Actually, my first clinical informatics project wasn't that. I've got to be honest with you. It was creating a scheduling system for medical students to schedule them for their outpatient pediatric rotations, which is something that they used at my medical school for about a decade after I left. Anyway, I've always been looking for computerized solutions for stuff in healthcare. And then when meaningful use came along and everybody wanted a CMIO, I just kind of climbed on board that movement and found my way into a wonderful job at Cincinnati Children's Hospital, where I've been for almost 17 years, working with their EHR project. And that's my story.
So, Kevin, apparently everything, all good informatics careers begin in the NICU. For me, I think it was the PICU, but for you, it was the NICU, just like with Andy. Tell us how it all started. We want to know everything about the neonatal ICU.
Well, for me, it began in the NICU, and apparently I decided to stay there since I'm still a neonatologist. But one of the things that I love about the NICU is that little things matter. And so when you talk about things like the volume of IV tubing, if you're given an adult, 3 liters of fluid, nobody cares about the 0.5 milliliter of IV tubing. But when you're running something at 0.1 milliliters per hour, that little bit of tubing matters. And so for me, it was always little things that matter. And that really, I think really appealed to my mathematical and kind of if this, then that computer type brain. So one of my first informatics projects what was in the newborn nursery, not necessarily the NICU itself, but it was there that I learned the importance of creating resources that impact people's workflow. And when you change someone's workflow for the better, when you design for the work that needs to be done, then you can make a lasting impact. So one of the things that I did was I created an Excel spreadsheet that you just fill it out with, of course, the birth information, and then every day you'd update it with the number of feeds, the number of voids and stools, and you put the bilirubin and all that stuff in there. And the cool thing was we used that tool both for rounding, because we'd print it off and we'd carry it around as we would go and see the normal newborns with our attending. But then we also, the very last cell in it was one that we didn't print off because that was the progress note for the day. And so basically, after you filled everything out, you just took that last cell and copied and pasted it into the electronic health record, and you could have all your notes written in 5 minutes or so. And I knew it was a success when I talked with my program director 3 years after I'd left, and he said they still had about 5 copies of it on a backup drive to make sure that nobody broke the Excel document that everyone used to write their notes in the newborn nursery.
Is somewhere an information security officer is having a headache, and they don't know why.
Absolutely.
But it works.
Because there's nothing in healthcare that happens outside the electronic health record these days.
Kevin, you are exactly right. And let's just keep going with that attitude. I do want to point out though that you were designing solutions to workflow problems, often with very, very basic technology, sometimes even on paper. And so it's not so much the technology part of informatics it often really just comes back to the information, and are you collecting it in an easy way and then leveraging it in an easy way. And I've been amazed at talking with clinicians who are involved in informatics. They always, not always, but almost always begin with stories like you've told of, well, I just had this problem and I solved it for me, and then someone next to me saw how well it worked, and then they wanted it, and then it just kind of goes by fire. And you got it when people are demanding. You've solved a problem when people are demanding that solution.
Yeah, absolutely. There's nothing that says in informatics that it has to be digital. You can start off with even with with paper or with magnets or other innovative ideas, and start with that as you're going through the design process.
Yeah, my first NICU application was just the set of printed tables, so it could do all the computations, pre-compute everything, and it would be transcribing the numbers to various places. But it cut out the whole step of having to get your calculator out. And I made it for myself. And one day the NICU director came over and said, "What are you doing? Where'd you get those tables?" I'm thinking, oh, my goose is cooked, because he was not known for being a kind man necessarily. He grabbed my tables and made about 200 copies of them, and I started distributing them to everyone else. I knew that perhaps I was onto something. So anyway, and they were basically spreadsheet printouts. So anyway.
Yeah, I think that's great. And as I mentioned, I think for me, it was in the pediatric intensive care unit, the PICU. And I was trying to order TPN labs, or trying to order TPN every day based on the lab results of the previous day. And I just couldn't figure it out unless I put it in a table in a way that was meaningful to me. And I created that for me. And on the weekend, I think on Friday afternoon, I gave it to another resident. And boy, oh boy, when I came back on Monday, everyone had them. And it was pretty cool. They took one of my copies and then made a copy and then whited out all the information that was there, and then made 200 copies. And there you go. That's how clinical informatics begins.
I think that just illustrates the importance of having that interface. And that's what we in clinical informatics, so often we just play the role of that interface between the clinical side and the clinical work that needs to be done, and the innovation, the electronics, the digital side as well, the computational side. So it's really fun. It's really fun being able to be that interface right in between with the content experts on both sides.
Yeah, well, it's good to be needed, and it sounds like we're going to be needed for a little bit. Andy, one of the things that when we were preparing for this episode, you told me that you're worried about a couple things. One of those is that all the rules are changing for clinicians and how they do their work. Well, and you mentioned an exhaustion discount. And I'm curious about who gets that discount. Is that 10%? Like, what is that discount? And how can I get it?
So the way things have worked since the mid 90s is we do things in clinical care, and then we document what we do. And the agreement is, if we want to get paid a little bit more, we document a little bit more. So it often seems like we're getting paid to document. I mean, it's not really true, but if you think about it in a certain way, it does seem like, the more you write, the more you get paid And that's not, and I fully understand that it's about the complexity of the care you're giving. I get that. But that we have this intermediate step of having to document it, which, as far as I know, no other profession works that way, but we work that way. And we all sort of know that writing a note for a very high level of complexity takes a lot of time. And we often get kind of tired, and we essentially downcode quite a bit, because we end up just saying, okay, well, this is good enough. I'm not going to, I'm going to maybe do my coding a little defensively, and maybe down code a little bit just to make sure I don't get into trouble. And we'll maybe not take the time to enter that extended service code that we perhaps deserve truly. I mean, that's probably the most neglected code there is all those extended service codes. But even some of the high level codes will downplay those, because it's just hard. It's just hard to document. You don't have time to document. You need to get home and all that sort of thing. So here comes AI. And we have this promise from AI that maybe we don't have to do documentation anymore. Maybe if the computer can pay attention to things that are going on and listening to the conversation and looking at our orders and taking notice of what's going on in the environment, that perhaps the computer can just generate the documentation. And if that's so, if that works, and that's a little bit unproven right now, but results seem promising from all the large language model-based systems that are being pushed now, then perhaps we will be able to code that extra service time and a higher level of service. And perhaps we won't have to worry about how difficult it is to write something, because the computer's doing it all for us. And so right away, one of the things that I worry about a little bit is, well, if the computer's listening and constantly tossing in CPT codes on our behalf and putting together notes, pretty soon that what I call the exhaustion discount, where you're just too tired to put it all together, will go away. And we'll start billing at a higher level of service and submitting more codes and charges. And, that's disruptive. It might be in perfect accordance with the rules. It might be exactly analogous to, or not analogous, but exactly compliant with the rules, and yet cost more money to payers than what it currently does. And that's going to cause some disruption and some hard questions. So the payers might say, well, gee, this care is costing more than it used to. It's all coming out professional charges. What's going on? And probably there's going to be some adjustment of what we get paid, and that will dilute the reimbursement somewhat. I'm predicting as we go to this. So will we end up getting paid more? I mean, everybody likes to get paid more, but is that really is that really what's gonna happen? And is it even necessarily the right thing? I mean, do we need to scour every second of our existence to make sure there's something billable out there, or do we just sort of have we reached a good equilibrium point where we document what we can get to and let the rest ride?
Well, it seems a little bit, to make an analogy, it seems a little bit like grade inflation. If everybody's getting the B plus to A plus plus plus, and so somewhere in there, we need to be able to pull out that that curve and come up with some differentiation. Who really is the complex patient versus the patient that just looks complex because the AI pulled a bunch of new diagnoses or a bunch of new things that we did to reach that next level of complexity.
And if AI is going to be looking over our shoulder anyway, one of the next things to happen is some suggestions like, hey, if you just bring up one more chronic illness and ask the patient how they're doing with this chronic illness that I found in the patient's chart, you could easily make this a level 5, something like that. There have been glimmers of this kind of technology for a while now. where if you, I used an EMR years and years ago that did something similar because you checked off all the review systems and that sort of thing. And it would give you suggestions for how to better support your level of service, which is dangerously close to something that sounds a little bit illegitimate. If someone's coaching you to charge more, that has a potential for causing some disruptions too. So it's an arms race. I think we all characterize our relationship with our payers as a bit of an arms race. We're trying to use tools to optimize our reimbursement, and as the tools get better, then the payers are going to say, "Well, gosh, maybe we shouldn't have been paying that much all along." So it's going to cause some reshuffling, I think, and we may end up in a period where the haves, the ones that have the AI assistants, will be getting paid a little bit more than the have-nots, and there'll be some interesting questions to answer.
Kevin, do you think that we'll be writing notes in 5 years or 10 years? Where do you think this is going? Are we not just going to record every clinical interaction? Maybe not in the hospital necessarily, but certainly in the clinic. Just record the interaction and keep that recording somewhere, and then everyone can have their own version of the note. The payer can have one version, and the quality folks another, and the clinicians a third. And if anyone has a question about what really happened, well, you just go back to the recording, which we're going to keep in perpetuity. Is that going to happen, or was that dystopian or utopian?
I don't think that the narrative will go away. And in fact, my hope is that the narrative becomes more of a focus, and then the other stuff that right now we're dumping into our bloated notes, that stuff kind of gets extracted in a way that becomes more, maybe more interactive. Maybe it's, why do I need to record the current ventilator settings in my NICU progress note? There's really no reason to do that other than to record a snapshot in time, which I will say, even though it might be unpopular, I will say that is actually useful. And right now, my EHR doesn't give me a great way to get that snapshot of what was it that I was looking at that moment in time to make that decision. But what I would love to do is I would love to remove a lot of the additional fluff, why do I need to write that I'm going to start Lasix at 1 mg per kg twice daily? Can't you see that I just put the order in? Like, just put that, that should just be able to be referenced somewhere. But why did I start Lasix at 1 milligram per kilogram twice daily? I mean, yeah, maybe AI could be listening to our conversation on rounds, and maybe it could transcribe something from that. Maybe that's what goes into a progress note or into the documentation piece. But I hope that the narrative does not go away completely, and rather that the narrative and then the objective piece get further defined by what is actually there and what is actually happening, that we are able to record in a structured manner in the whole electronic health record.
Yeah, I finished my residency in 91, and the CMS guidelines for documentation came out in, of course, 95 and 97. So I was around for a lot of those classes for how to document, and I remember having the thought, why don't we just get a whole bunch of, I think at the time the technology was Betamax. We may not have had VHS quite yet, but so why don't we just get a whole bunch of tapes and just tape everything, and anybody wants to know, they can just, we can send them the cassette, But I truly think that documentation as we know it today can be and should be made illegal. There, in the sense of it's forbidden to waste a physician's time in this way. I mean, it's almost immoral to take a rare resource like that and have them sit around and document all kinds of things that already exist. I mean, I agree about Kevin's comment about how you want to maintain a narrative, and you want to have, you want to keep some notes for yourself and for your cross coverage and for for the family to understand what's going on. I mean, that's a far more important objective than a lot of the other things that we write notes for. Everybody talks about, well, we write a note because of billing. Well, it's not the only reason we write notes. We also write notes, at least when we're trainees, we write notes because we want a script to read from. We want to have every piece of information there so that nobody has to find us looking in the chart for something. It's all going to be written out right there, so I can just look at my note and talk. And that habit sticks with us, and we end up on past our residency, just writing these long scripts where we record every little piece of information. And people justify this by saying, hey, I want to do my thinking in this note, and I want to bring all the things I need to contemplate into one artifact. And I can certainly understand that. Sometimes, I mean, there's complex thinking to be done, and you don't want to be overloading your head with where to click next. But the computer's got to help us here at some point. And I think I'm hoping in 10 years we'll look back at what we ask ourselves and our trainees and our colleagues to do, and just declare that to be a ridiculous waste of time that the computer can now help us out a lot more with.
Well, Andy, speaking of helping us out, there was a recent study that showed that an AI can be more empathetic than a physician in terms of from the perception of the patient. And where do you think that's going? Are the computers just better listeners, and doctors are just bad? I'm not saying that, but I think you are. No, you're not.
No, I'm not. So first of all, you're referring to the UCSD study where they looked at physicians' replies on Reddit. I'll say that again. Physician replies on Reddit to things that were generated by a large language model that had been instructed to be empathetic. Okay, you take a large language model and you tell it, please be extremely polite. It will be extremely polite. That's because that's how large language models work. Okay, unless they're just malfunctioning or something. And even if this, I don't know where you'd get physician replies besides Reddit. I guess you'd get it from an EHR, but that would be a little bit HIPAA risky to do that sort of study. But you can take these large language models and ask them to be however you want them to be. And anyone who's been on hold at a car rental agency is familiar with the almost obsequious tone of the little chatbot that pops up, and how profusely apologetic it is about your wait time and all this kind of stuff. And I would just remind people of what happens every year when college acceptance letters come out. Every letter that goes out that's saying you didn't get in starts with the phrase, "We regret to inform you." And we look at that phrase, it's almost invisible at this point because we know that a rejection letter starts that way. But here's the thing. Does anyone actually regret to inform you of that? Is there someone sitting at Yale going, gosh, that kid really should have gotten in, and I'm racked with regret? No, I mean, of course not. They're just being polite. So my question is, we hear a lot about how this large language model can create the very empathetic, very have a nice bedside manner and give you a very nice and polite response, but it's just doing what it's being told to do. And the question is, is anyone really being fooled by that, or is there any value in saying, oh, AI is valuable because it's polite? I don't think so. I think AI can be as polite or as rude as you tell it to be, and I don't think it really matters to people. Once they realize that it is a bot, then it probably doesn't matter that much anyway. I mean, if you knew that as everyone does, that letter from the college telling you didn't get in was a form letter. I mean, everybody knows that. And they obviously understand that there is no regret. And that's what the letter template says. Nobody actually had that thought. When the same thing is applied to a response, to an AI generated response to a request, and it's extraordinarily empathetic, is that a good thing? I guess, but is it important? I don't think so. So, I mean, I don't see it as a major driver toward rushing toward AI. It's just because it's quote more empathetic than a doctor. I think that depends on the doctor and depends on the AI model.
I think that concept is probably more helpful when it comes to maybe synthesizing or summarizing or basically coming up with communications for families or others to know what's going on. So if I write my NICU progress note in a way that I know that I do write my NICU progress note in a way I know that I'm communicating with other healthcare providers so that they know what's going on with that patient. I think that is appropriate. That's what I'm using that note for. I know as well that 21st century cures, absolutely. The parents are probably getting in there and looking at some of that as well. Looking at some of that information. But I don't try to change my tone of my medical progress note for a family. But how great would it be if my progress note was all of, I don't know, 2 or 3 sentences on the actual progress for the day. This gets back to what I was saying earlier about synthesizing the what I'm actually thinking. And then the additional information could be added by AI, perhaps in a very compassionate and just understanding manner, and a way that's written for that family to be able to understand. Maybe the family even has little sliders. They can adjust the amount of medical jargon on there. After they've been here in the NICU for 7 months, they probably understand a lot more than they did on their 7th day.
Yeah, I've seen functionality where you can highlight a piece of text in an EHR and you right-click on it and say, rewrite this at the 3rd grade level or rewrite this at the 8th grade level or something. Sure. Why not? I mean, to your illustration earlier, Craig, about having a recording someplace, and you can output the results of that recording for various use cases. This is here's the oncology progress note for the family, and here's the oncology progress note for the payer, and it's all the primary data is the same. It just has multiple outputs that look different. Right now, that's a manual process, so it's not going to happen really. But as we get better, why not stick to the original data, the audio recording, video recording, the orders, the log of the user actions. Just keep it simple. Keep it. That's the primary information that tells the universe that some care got done. And this business about having to write it up in various ways, I hope we can get away from that and just say that's not appropriate. I mean, if you're spending time doing that as a doctor, you could be doing other much more valuable things instead. So let's do that, and not do all this writing of stuff. I mean, imagine if imagine any other profession that. You take your car to an auto shop and they tell you what the parts cost, what the labor was, and there's your bill. Well, instead we say, oh no, I want you to describe exactly which rack the car went up on and what you did first and who you talked to and all this detail. It's like, I get that there's a lack of trust. I mean, it's all based on a very well justified concern about fraud. Okay, but we spend so much time doing all these notes, and it's a waste of a precious resource, honestly.
Yeah. So first of all, very interesting comments, and I think that those are pretty mainstream views. Physicians are burned out. We know this. Clinicians people that work in the hospital, clinicians or not, are burned out, and part of the reason is this documentation and kind of detail oriented writing that is required to get people to not get sued and to be able to get paid. One thing though I saw regarding empathy from a large language model, I read this discharge summary for a new onset diabetic, I think a 9-year-old, something like that, and they asked the LLM to consume the chart and to write a discharge summary for the both the clinical one and also patient instructions. And I was amazed at reading this, and this is probably because I'm not a pediatric endocrinologist, but there was a line in there that said, Johnny, you might think that it's your fault that you got diabetes, but this is not something that you can control. To me, that was pretty revolutionary, because now, again, if I'm a pediatric endocrinologist, maybe that's a common thing, and kids often wonder even if they don't say that they're responsible for their disease. I thought that was great. Like, that's something that I would love for someone to point out to me, or something to point out to me, like, hey, the patient didn't say this, but you didn't ask, and they statistically are thinking it, so you might as well try to address that elephant in the room. That's pretty amazing, and that's a service I want.
Yeah, going back to this idea of having primary data somewhere that generates different outputs. It should be, I guess at some future date, it should be queryable. Well, if you've got a concern, what could I have done to prevent my child's type 1 diabetes at age 9? You might ask a doctor about that too, but why not ask the data too? If we're really getting into this, all this AI stuff shouldn't be just to generate notes. It should be to help with communication and to actually take data and turn it into information.
Yeah, makes sense. Kevin, we like to talk about design and healthcare at a very high level. You have said previously that you consider yourself an informatics generalist. And to me, that makes me wonder, what's an informatics specialist, and how do they do their work? How do they design their workflows? How do they address technology in a different way? So what do you mean by informatics generalist?
Yes, yeah, that's that I like that distinction. What is an informatics specialist then? Well, I think it gets back to a little bit just me personally. I really love delving into all things informatics and at least having an idea of how things work. So I can talk about things like machine learning and artificial intelligence and neural networks, and I have a general understanding of how they work. And I've played around with them a little bit, and I think that's fun. But I don't necessarily consider myself to be, say, a machine learning expert. That's not what I'm doing day in and day out. Over time, I found myself really acting more in that role of the interface between that clinical care and the processes, the workflows that need to happen. And one of my specific interests is in programming. My wife calls it my Sudoku, so I love getting in there and trying to figure out how to get the computer to do to do what it is that I want it to do. Whether that's creating an algorithm, a deterministic algorithm, or having it respond to different user interactions and that kind of thing. So I think it's important that we as clinical informaticians, that most of us are informatics generalists, that we can do things where we can build directly in the electronic health record. We can speak to things like usability with effectiveness, efficiency, and satisfaction of use. We can evaluate workflows, and then we have an understanding. I think it's really important that we that we have that understanding of neural networks, artificial intelligence, machine learning. How do all these things work, and how can we respond appropriately and intelligently as informatics generalists?
I love it. And I think you've commented also previously that only pediatricians should be allowed to be informaticists. Did I get that quote wrong?
I think that's the gist of it in general.
Why? What's so special about you pediatricians?
Well, I mean, specifically, I think with machine learning. Obviously I don't completely think that, but I do think that pediatricians, or really doctors in general, have an advantage when we start talking about this machine learning concept, because we do have an understanding of how the brain works and how we as humans learn. So we understand things like neurons and axons and myelin sheaths. And really, if you think about a neural network is it's basically a bunch of linear algebra matrices that all kind of get scrunched together. I realize I've just lost everybody, so sorry for ruining your listenership here. But that's basically all you're doing is you're reinforcing the myelin along those linear algebra matrices, and we understand how somebody goes from, if we think about somebody learning to ride a bike. When they first start, there are a lot of scraped knees and not a lot of bike riding that's going on. But through continual reinforcement, you can see that the child is gradually learning to develop their balance, and every time that they're doing something, they're getting a little bit of feedback, and that keeps on reinforcing. And that's the way that the neural networks work as well. Just instead of reinforcing myelin sheaths, you're adding a little bit to the numbers here and there, so that one input is weighted more than, say, a different input to get to the outcome.
I like that. I agree. Maybe for a slightly different reason. I've often said that pediatricians are good in the informatics and the CMIO, CHIO type roles, because we're used to dealing with children. And there's some smiles there. I'm not saying that physicians act like children often, nor am I calling out various specialties such as surgeons. I'm not doing that. But there are others who have done that, and, to each their own. Andy, thoughts about this?
Well, I think if you're I met a informaticist recently who had been a neurosurgeon, and I thought, who in the world would give up a career in neurosurgery to be an informaticist? And the answer was he was from the UK, and he explained to me that all doctors essentially all earn the same amount of money in the UK, and so wasn't that big a loss to him to switch over to informatics. And perhaps the reason why we have so many pediatricians and hospitalists in the informatics ranks is because folks who can earn a lot more money doing their specialty aren't as tempted to spend time on things like this.
Andy, you really you're bumming us out here. Kevin and I are bummed out now because
that's my value add.
I do think that one of the reasons, though, that you'll find a lot of pediatricians that are thinking in the informatics mindset is that in pediatrics, especially in that like subspecialty pediatrics, we're almost always dealing with rare diseases. I mean, if you think about it, kids are not supposed to be in the hospital, and so whenever we are dealing with something, it's not something that wouldn't necessarily be dealt with in mass. And frankly, in many cases, it's taken a while for our electronic health record to add some of the pediatric specific or pediatric friendly functionalities into, say, our electronic health record. And I also think so oftentimes we have to deal with things like workarounds, or using tools or medications in ways that are maybe a little more creative. I already talked about being in the NICU, and one of the things that I love about it being that I have to deal with the little tiny things, the very small changes in the volume of ventilation. I have to think about things like dead space in the airway. It's those little things and those edge cases that I think lend themselves to thinking like an informaticist as well.
Typically at the end of our podcast, we like folks to tell us if there's something that is so well designed in their lives that it brings them joy and happiness. And sometimes it's technology and sometimes it's not. Kevin, let's start with you. Is there something, are there one or two things that just are so well designed they bring you joy?
Well, the thing that immediately comes to mind to me is I like to focus on, and I talk about usability often, and with the three pieces of usability being the effectiveness, the efficiency, and the satisfaction of use. And when I think about that, one of the best examples is when you mistype your password on a Mac. Do you know what happens? Have you done this? That's right. When you mistype your password, the entire screen shakes at you. It's like, hey, you idiot, you just mistyped your password. And I love that because is it effective? Yeah, it told me I just typed my password wrong. Is it efficient? Sure, doesn't take very long. I don't even have to click on a box to say, you got to retype your password. And is it satisfactory? Yeah, I can kind of laugh at myself because my computer just shook its head at me. So I think that's great.
That's awesome. Andy.
Yeah, there's so many things, but since this is a computer-oriented conversation, I have to. There's a vector drawing application that I love. I'm not, I don't know if I can mention the
please.
It's called OmniGraffle, and it's a Mac only product. I don't honestly know why they don't make one for Windows. It would work perfectly well on that platform. Maybe someday they will, but it is just you can immediately tell if a person didn't use this program in a diagram. It's because it's going to look clunky. It's going to look crude. It's going to look like an 8th grader had a really good try at it. Whereas with OmniGraffle, you can make it look just beautiful with every pixel in place. And I don't know. There's certain things like that in this world that bring me joy. And since we're down this path, I'll just continue one more. There is a programming language. The first programming language I learned called APL, and it stands for a programming language. And those who know APL know exactly what I'm talking about. But there was a book on APL by Kenneth Iverson that just took you through just teaching you the language. And it's still the best textbook I've ever laid my hands on. I still have my APL book that I bought when I was in 7th or 8th grade. And it's just the most amazing exposition of a complex topic that I've ever seen. So anyway, those are a couple of things.
Well, I am joyful because both of you mentioned Apple products or software that runs on Apple machines, and I'm a big fanboy. So this is a terrific way to end. Thank you so much. Really appreciate it. It was a very interesting conversation, and look forward to continuing it at some point in the future.
Well, I do have to say, my Microsoft Surface that I still have right here, version 3, is it will blow your Apple anything way out of the water. But good luck with that.
I'm crushed. And I'm giving you 50-50 odds that I'm going to take that out of the podcast. But let's see. All right. Thanks again.
Thanks.
Thank you.
Thanks for tuning in. We hope you enjoyed today's episode. For more information, visit CincinnatiChildren's.com. Plus, visit the show notes for this episode for a link to Dr. Spooner's Pinterest page filled with his favorite well-designed things. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.